Welcome to AETCM, the emergency medicine channel. Today's our topic of discussion syncope from neurological emergency. So our content of our presentation definition, what is the reason for the syncope, causes, clinical manifestation, assessment, management, and finally how we are differentiating between the seizure and then syncope. So definition wise, syncope is a symptom, it is not a disease. So it is not a disease, it is one of the subjective data. So syncope or fainting, both are same term only. Means that is a sudden temporary loss of consciousness. So it will occur suddenly. Mean the same time it will persist only for only within a second only, not more than a seconds, right? So that is why we are calling as a temporary loss of consciousness, and then it may be because of various reasons. It may start with a simple orthostatic hypotension to stroke to dysrhythmias. Various causes are there. So what the reason behind the syncope? So the brain uses glucose at an astounding rate, has no ability to store the glucose. It will use lot of glucose, but it doesn't have a storage box. That is why it have a no ability to store a glucose. If you are providing a continuous glucose, if you are providing a continuous supply, means it will work out. Or if you cut off your circulation, means that will sleep. That is the thing. So even a 3 to 5 seconds of interruption in a blood flow, that will cause the loss of consciousness. That is why if you are providing continuous supply, means that will work. If you are stopping your circulation, means that won't work, or that will sleep. So that is the reason for the syncope. So causes we are categorizing into cardiac and then non-cardiac. So wherever you are reading regarding the perfusion, just apply your perfusion triad. So perfusion triad: content, container, and then pump. So if you apply these three things, easily you can remember all the causes. Here first we are going to deal about the pump or cardiac related causes. Again, cardiac also we are categorizing into two categories. First one, cardiac rhythm related, second one, other cardiac causes. Okay, so cardiac rhythm wise, bradycardia, sick sinus syndrome means triple S. Sick sinus syndrome means that is some problem in your sinus node. From sinus node itself problem will occur, so the alteration in the rhythm will occur. Supraventricular tachycardia, SVT, pacemaker malfunction, dorsal points means that is your polymorphic ventricular tachycardia, and then transient asystole will cause the syncope. Transient ventricular fibrillation also, ventricular tachycardia, Stokes-Adams syndrome. So it is also one of the disease. In this there is a lot of ECG rhythm alteration will be there. There is a tachybrady syndrome. Means tachybrady means there will be a first in ECG, if you see, means tachycardia will be there, bradycardia will be there, in between asystole will occur. Likewise, because of the rhythm alteration, that will causing the syncope. So other causes like cardiomyopathy, myocardial infarction, and then cardiac medications like beta blockers, alpha blockers, nitrates, digitalis, diuretics, cardiac valvular insufficiency, aortic stenosis. Stenosis means narrowing, and then ball wall thrombus. Ball wall thrombus means that is a floating blood clot that will be in your right atrium or left atrium or in the left ventricle. So whenever we are leaning forward, the clot will move, and then that will obstruct the outflow. That is called the ball wall thrombus. Mainly it will obstruct, mainly the syncope will occur in the case of leaning forward. So in Stokes-Adams, even in a supine position also, that will cause the syncope. So this is the difference between the Stokes-Adams and then ball wall thrombus. Other non-cardiac related, others means container and then content related. So there is a dehydration, hypoglycemia, vasovagal. Vasovagal means there is a parasympathetic nervous system. So that will cause the vasodilation, bradycardia. Because of that also occur orthostatic hypotension, pulmonary embolism, situational during urination, swallowing, coughing. So what will happen means in situational, there is a increased intrathoracic and then intra-abdominal pressure. So because of that increased intrathoracic pressure, venous return will reduce. Venous return reduced means output also. So input reduced means output, cardiac output also will reduce. It's a situation. Other medication like alcohol, cocaine, opioid analgesic, tricyclic, antidepressants. So clinical manifestation wise, pre-syncope and then syncope. In pre-syncope, early symptoms and then late symptoms. In early symptoms, the person will feel a nausea and then heavy perspiration, loss of color, the pale ash and grey skin tone will occur. Late symptom, pupillary dilation, mydriasis, bradycardia, visual disturbance, dizziness, hypotension. During the syncope state, there is a four major things: decreased blood pressure because of the weak pulse, bradycardia, irregular breathing, and then pupil dilates. Mydriasis. In post-syncope state, pallor, nausea, sweating from minutes to hours, BP and then heart rate that will become normal, and then tendency to second attack when again if the person syncope because of the orthostatic means, again if you are changing his position means, that is a second attack also may occur. So assessment wise, majorly in the case of adult, syncope will occur because of the vasovagal stimulation. So vasovagal means, as like we told, vasovagal, in the case of vasovagal, there is a stimulation of parasympathetic nervous system. So that will dilate your blood vessel and then that will reduce your heart rate. That's a bradycardia and then vasodilation. So the adult experience fear, emotional stress or pain. The person then suddenly experience spinning sensation and then blackout of the vision. But in the case of older adult, the major cause for that syncope is a cardiac dysrhythmias. So here the person experience sudden ventricular tachycardia, and then because of that blood pressure will drop, because of that the person fall on the floor, that is causing the syncope. So the rhythm terminate, blood pressure rises normal means again the person will become a normal state. So it will take less than 60 seconds. So major important thing in adult means it will occur because of the vasovagal. If it is a older means cardiac arrhythmia is one of the major causes for the syncope. So again, syncope usually experience a prodrome. Prodrome means something that some clinical manifestation that will occur before the some disease. So likewise, if it is in syncope, there is the person will feel the dizziness, weakness, shortness of breath, chest pain, headache based on the condition. So or the patient stating his or her vision went black. So blackout of vision also will occur. Incontinence is possible with syncope, urinary incontinence. So history or assessment wise, whether the person feeling hot or he or she standing for a long period or he or she performing strenuous activity, did the patient need to bear down while lifting something heavy, was any history of alcoholic. So those are things we have to rule out. For investigation, if it is in hospital, we can go for blood glucose level, ECG, echo, treadmill or Holter EEG monitoring, electrophysiological study, and then carotid sinus massage to rule out the any carotid sinus related things. So again, that is a Valsalva manner, right? So that also will perform. BP to rule out the orthostatic hypotension. So we'll take for orthostatic hypotension, first you have to take the blood pressure in supine position. After 3 minutes you have to ask the then after that you have to ask the person to stand, and then we have to wait for 30 minutes, and then we have to take out the blood pressure. So that also one time we discussed in the cardiovascular emergency. And then this is a overview. Again, if it is a in hospital, if it is a pre-hospital means we can perform, if you want to rule out any cardiac related causes means we can go with an ECG, and then we can rule out the other causes. So dehydration means there will be hypotension, so cardiac monitoring, so dehydration related assessment we can do. If it is in hospital, the what are the things we told, the EEG and then electrophysiological study and then treadmill test that will carried out in the definitive care. So this is the overall things what we are doing in the in hospital. So first we have to do the ECG and then cardiac examination. If it is not a normal means, so if any problem in the ECG and cardiac examination means, so furtherly we have to dig out. For that we are going the treadmill test, Holter monitoring, echo test. But if it is a ECG and cardiac monitoring is a normal, examination is normal means, then you have to rule out whether the loss of consciousness is within a second or less than a second, that we have to rule out. If no means, if it is the loss of consciousness more than a second or more than a minute means, so we have to additionally we have to rule out the seizure. If yes means, then we have to precipitate by standing. Whether it is because of the standing it is occurring means, if yes means, that is because of orthostatic syncope. If no means fall without hurting self. So that is because of the psychological evaluation we have to do. No means that is a probably vasovagal syncope. So management, straightforward, scene size up, and then we have to assess the mental status, treat the life-threatening causes, and then administer the oxygen if it is needed. So the first step of management in the syncope, we have to determine the trauma. Again, the same thing only. So even in elderly cases, with a small velocity, they will get a higher amount of that injury will happen. So higher level of injury will happen with a small velocity. So we have to rule out the any trauma related history. So if it is, if we are suspecting trauma means, then you have to manage the manual inline stabilization. So if not mean, we can position the patient head down and then lower limb elevated position that we can do. Next you have to focus on the blood pressure, and then blood pressure we have to stick. If it is orthostatic, we have to rule out means, if the person is stable means, we can take out the blood pressure also. To treat the hypotension, first we have to give the fluid bolus, that is a crystallite fluid bolus. We can give the 500 to 1 liter, 1 liter of crystallite fluids, normal saline we can suggest. So again, if it is refractory to the fluid resistation means, then we can go with an vasoconstrictors, that is a noradrenaline vasoactive medication, 0.1 to 0.5 micrograms per kg per minute we can administer. Again, if the person have a syncope because of bradycardia, sinus bradycardia means, then we can go with an atropine 1 mg. So the maximum dose is 3 mg. Still, if the person refractory to this thing on means, then we can go with an transcutaneous pacing. Again, if it is refractory means, you can go with an infusion of your dopamine and then epinephrine infusion. So those are the protocol for the bradycardia. So arrhythmias, if the person have arrhythmia means, then we are suggesting the anti-arrhythmic drug. For that we are using the amiodarone, right? So the first dose we have to give the 150 mg over 10 minutes, followed by 1 mg per minute for 8 hours, 0.5 mg per minute for the 16 hours. So 8 or 24 hours we are not going to give in a pre-hospital, just for the remembrance you can remember. So the anyway first 10 minutes will we can follow. So 150 mg over 10 minutes. So how we have to dilute? So usually amiodarone will come in the form of 3 ml, this one ampule, right? So 3 ml ampule, each ml contains 50 mg, right? So total 3 ml will contain the 150 mg. So how we have to dilute? First take the, here we have to dilute in the D5, okay, dextrose 5. So D5, take the 47 ml. So for 47 ml of D5, along with this you can add the 3 ml of amiodarone. So totally it will come 50 ml. So this 50 ml you can administer over the 10 minutes. Followed by, we have to go with an 1 mg per minute for 8 hours, 0.5 mg per minute for 16 hours. How we have to dilute? Those are the things. Just for remembrance, I am telling dilution purpose, but mainly we are not using in a pre-hospital situation, that infusion and all, just for remembrance. For 1 mg per minute means, here you have to take the, so we told 3 ml contains 150 mg, right? That is the 1 ampule. Here you have to take the 6 ampules. 6 ampules of amiodarone. So 6 ampules means that will comes around 900 mg, right? So in for dilution we are taking the dextrose 5, that you have to take the 450 ml. 450 ml of dextrose 5. So here 900 mg of, so you have to add in, so each ml contains 2 mg. Am I right? So 450, 900, so each ml contains 2 mg. So 2 mg per ml. So our goal is 1 mg per minute. Per minute. So you have to calculate in the hour, right? Hour. Per hour means 60 mg per hour. Here 0.5 mg per minute means, per hour if you are calculating means 30 mg per hour, right? So here, but we have a 2 mg per ml. So 60 mg we want means, so we can administer the 30 ml for first 8 hour. Here we told 30 mg. So half of the dose for the 50 ml per hour. per for the over 16 hour. So I think easy to remember, just take the 906 ampules of amiodarone and then D5 you can take the 450 ml. So each ml contains 2 mg, but here we want a 60 mg per hour. Here we given a calculation of, they were given a calculation of 1 mg per minute. So you have to convert into hour. For that you will get a, so 60 minutes it's a 1 hour, right? So 60 mg we need. 0.5 mg means 30 mg per hour, that is the desired dose. So here, but we told 2, so each ml contains 2 mg, but we want a 60 mg. For that you can administer the 30 ml, 30 into 2, that is the 60 mg. So there if you divide it into 2 means 50 ml is equal to 30 mg. So this is the difference between the seizure and then syncope. So any precipitating factors in seizure, nothing is there, but syncope, emotional stress, valsalva, orthostatic hypotension, cardiac etiologies like arrhythmias. So symptoms before onset, in seizure no symptoms, but in syncope tiredness, nausea, diaphoresis, visual problem. Position change, that will in seizure nothing will cause, but in syncope usually standing will cause the orthostatic hypotension, because of that syncope can occur. Sorry. Loss of consciousness in seizure, that will immediately will occur, but in syncope it will take gradually over a seconds. Duration of unconsciousness in seizure, it will take within a minute, but in syncope within a seconds. So duration of tonic and then clonic movements in seizure, it is about the 30 to 60 seconds, but in syncope there is no such activity. So facial appearance in the case of seizure, that is a cyanosis, tongue bite and then frothing at the mouth. But in the case of syncope, there is a pallor appearance. So confusion after and drowsiness after convulsion in a seizure, many minutes to hours, but in syncope there is a confusion less than 5 minutes. Muscle cramps after a convulsion usually occur in the seizure case, but sometimes that will occur in the syncope case. So urinary incontinence, both seizure and then syncope, sometimes it will occur. Headache also in seizure, it usually sometimes it will occur, but in syncope rarely it will occur. So do your best. Shalom.